Hello, my name is Professor Lorraine Hu. Welcome to the Health and Physical Assessment. I'm going to talk about a comprehensive patient interview. Now, the interview is an art and skill you will develop and get better at it with experience and practice. The interview and health history information can give us more information than a skilled physical exam. Even with the time constraints of appointments, you must do your best to take your time with the patient's history and not jump to conclusions before pertinent information is learned. This could lead to an incorrect diagnosis. Some clinical pearls to remember: sometimes it is necessary to save non-urgent or less significant problem discussions for another visit scheduled soon after that. Focus on priority issues that need your attention. There are different kinds of health histories. The scope and detail of the history depend on the patient's needs and concerns, your goals for the encounter, and the clinical setting, whether it's inpatient or outpatient, the amount of time available, primary care, or subspecialty. You will perform a comprehensive health history for new patients in most settings. For patients you see for the first time in the office or hospital, you will usually choose to conduct a comprehensive assessment, including all the elements of the health history and the complete physical exam. You will find that not all assessments need to be comprehensive. You will adjust the scope of your history and physical examination to the situation at hand, keeping several factors in mind: the magnitude and severity of the patient's problems, the need for thoroughness, the clinical setting, whether it's inpatient or outpatient, primary or subspecialty care, and the time available. Only areas that relate to the symptoms are investigated to develop a plan for physical examination and assessment. For patients seeking care for specific concerns, for example, cough or painful urination, a more limited interview tailored to that specific problem may be indicated. This is sometimes known as a focused or problem-oriented history. In many situations, a more flexible, focused, or problem-oriented assessment is appropriate, particularly for patients you know well returning for routine care or those with specific urgent care concerns like a sore throat or knee pain. If there is a specific complaint, the history of the present illness or HPI must be fully explored. For a patient whose chief complaint is a sore throat, the provider must do a thorough history in head, eyes, ears, nose, throat, and respiratory, as well as reviewing habits such as smoking that can worsen the symptoms. In addition, work and home environments are explored to ensure no contributing factors are present at home or work. The focus assessments help to direct the physical examination to the body system which are affected. You will use the mnemonic OLD CART, which stands for onset, location, duration of the symptom, as well as any accompanying symptoms, aggravating or relieving activities, and what the patient has tried to for treatment must be discussed. Here's a slide for all CART: onset, location, duration, characteristics, aggravating factors, relieving factors, and treatment. So the purpose of learning for week one's patient interview, so you're doing a comprehensive interview, so you got to keep it simple. You may coach your patient to provide limited past medical history. It is fine for them to say if they have a history of hypertension or hyperlipidemia or asthma or thyroid disease or even minor aches and pains, because this will give you something to write about in your notes for risk factors or risk assessments. But ask them to keep the interview um, not complicated, because this is your first attempt and you're learning how to interview a patient. So you're learning the technique. Um, what the previous actually slide, I missed a couple of uh, kinds of health histories. So here they are. For patients seeking care for ongoing or chronic problems, focusing on the patient's self-management, response to therapy or treatment, functional capacity, and quality of life is most appropriate. Patients frequently schedule health maintenance visits with the more focused goals of keeping up screening examinations or discussing concerns about smoking, weight loss, or sexual behavior. And then a more focused, comprehensive history would be if the patient went to see a specialist, so they would need a more comprehensive history to evaluate a problem with numerous possible causes. So, what are the components of the comprehensive adult health history? So, these are the 7 components: initial information, chief complaint or complaints, history of present illness or HPI, past medical history, family history, personal and social history, and then review of systems, so ROS. So I'm going to go over a little bit more in detail the components of the comprehensive adult health history. So the first one is initial information. So you introduce yourself to the patient and lead the conversation. So you basically have to lead the conversation. That's important. You can say, "Hello, I am Lorraine Hu, and I will be your student nurse practitioner taking care of you today, and I will be asking you many questions during this interview so that I can better understand and take care of you." So wash your hands. You may shake the patient's hands after that. Ensure privacy and confidentiality. You are identifying data such as the patient's name, age, gender, occupation, marital status, source of information, and source of referral. Start building a relationship with the patient. So the source of the history usually is the patient, but it can be a family member, a caregiver, or a friend, or the clinical record. Reliability varies according to the patient's memory, trust, and mood. Also, is there anyone in the room that the patient might not feel comfortable speaking in front of? So make sure the patient has complete privacy to speak about everything that is bothering them, even if it is their mother, uh, father, partner, or whoever it is. The patient might not want to speak in front of them. Ask the patient if they would like to continue on their own, and if they agree, politely ask them to leave the room. Adolescents must be 18 years and older to proceed on their own. So you start the patient interview by mentioning everything you will discuss in this session. Just make sure that the patient knows exactly what is going on so they can keep up and formulate questions. This also includes going in a chronological order that makes sense to the patient and yourself. What I'm saying here is don't start your interview explaining treatment measures without thoroughly explaining the actual condition to the patient and allowing time for any questions they might have. Providing good instructions to your interview makes it easier for you to flow through the multiple phases without forgetting anything. Chief complaint: the primary symptom or concern causing the patient to seek care. This can be put in the patient's own words with quotation marks. In this assignment, you should coach the patient, who could be either a family member, friend, neighbor, or classmate, to say that they are here for their annual visit. For this assignment, you are only completing the subjective portion, not the objective. What is the difference between subjective and objective? Subjective information includes symptoms, which are health concerns that the patient tells you. Examples include complaints of a sore throat, headache, or pain. It also includes feelings, perceptions, and concerns obtained from the clinical interview. Chief complaint and from the review of systems sometimes obtained from the chart or the family. One type of objective information is the physical examination findings or signs you detect during the examination. All laboratory and diagnostic testing results are also considered objective information. For example, chest pain is a subjective information, while tenderness on palpation of anterior chest is an objective one. Knowing these differences help you group together the different types of patient information. These distinctions are equally important for organizing written and oral presentations about patients into a logical and understandable format. So once again, here are the 7 components of the comprehensive health history of an adult, and these information are subjective data. So identifying data, so who it is, chief complaint, history of present illness, past medical history, family history, personal and social history, and review of systems. So we're going to go over each of them in a little bit more detail. History of present illness, or HPI. The HPI, in its most basic form, is the story of the patient's problem. It should reveal the patient's responses to his or her symptoms and the effect the illness has had on his or her life. HPI is a concise, clear, and chronologic description of the problems prompting the patient's visit, including the onset of the problem, the setting in which it developed, its manifestation, and any treatments to date. However, you might be tempted to let the patient lead the conversation by telling you what is wrong and how they have progressed. Starting and taking hold of the reins of the conversation is crucial. You want to guide the patient in this conversation while maintaining their perspective. For example, a talkative patient telling you all about their ailments, recommendations for patient centered communication may not work on talkative patients. These recommendations mainly propose the use of skills that invites patient to talk, such as active listening, asking open to close-ended questions when appropriate, not interrupting the patient, facilitative responses, and clarifying statements. When seeing talkative patients, the practitioner senses that their quest for information potentially conflicts with other goals such as relationship building and time management. Interrupting a talkative patient on repeated occasions, for example, may be necessary to keep the patient on topic, yet it may jeopardize patient's feelings of being heard and thereby the practitioner patient relationship may suffer. But dealing with such goal conflicts is challenging for us. After listening to the patient talk for about 4 to 5 minutes, you may want to redirect and validate what was said. Ask the patient for their number one concern today. Tell the patient that you have time limit and maybe see them again in a few days to finish. Remember that does not mean that you should not allow the patient to talk freely. Sometimes the stories are the keys to diagnosis. And then then use the 7 attributes of a symptom to describe each symptom or problem. So that's your old card. Okay, that's the 7 attributes of symptoms um, to describe each symptoms or problems. Include risk factors for disease. You can list medications that they're taking and the allergies that they have, either to food or medication. Past medical history. These list the adult's illnesses with dates for events in at least 4 different categories: medical, surgical, obstetric, gynecologic, and psychiatric. So you may list the childhood illnesses, including health maintenance practices such as immunization, screening tests, lifestyle issues, and home safety. You may want to ask what diseases has the patient had. Has the patient fractured any bones? Are the recommended vaccines per CDC guidelines up to date? It may include medications and allergies as well. For the past surgical history, you may want to ask what surgeries, if any, they've had, approximate dates and years of the surgery. When speaking to the patient, try to be as clear as possible, using the simplest term without compromising meaning. You want your patient to understand you perfectly and the condition clearly. So therefore, avoid using medical jargon. Family history. is a record of health information about the patient and his or her immediate relatives. Try to go back 3 generations if possible. Use a genogram. It lists the age and health or age and cause of death of each immediate relative, including parents, grandparents, siblings, children, and grandchildren. Review each of the following conditions and record whether they are present or absent in the family, such as hypertension, coronary artery disease, elevated cholesterol levels, stroke, diabetes, thyroid or renal disease, arthritis, tuberculosis, asthma or lung disease, headache, seizure disorders, mental health, suicide, substance abuse, and allergies, as well as symptoms reported by the patient. Ask about any history of breast, ovarian, colon, or prostate cancer. Personal and social history. The social history includes the patient's personal history, which captures their personality and interests, coping style, strengths, and concerns. It attempts to personalize your relationship with the patient and builds rapport. This personal history includes their sexual orientation and gender identification, place of birth and personal environmental map, occupation and education, significant relationships, including safety in their relationships, home environment, including family and household composition, important life experiences such as military service, job history, financial situation and retirement, leisure activities, sexuality, spirituality, and social support systems. The baseline level of function and activities of daily living is significant in older adults or patients with disabilities. Other parts of the social history include tobacco, illicit drug, and alcohol use. It also includes lifestyle habits that promote health or create risk, such as exercise and nutrition, including frequency of exercise, usual daily food intake, dietary supplements or restrictions, and use of uh, coffee, tea, and other caffeinated beverages. Safety measures include use of seat belts, bicycle helmets, sunblock, smoke detectors, firearm, and other devices related to specific hazards. Sexual orientation and gender identification. A supportive, non-judgmental approach is essential for exploring your patient's health and well-being. While social relationships are the central source of emotional support for most patients, they can also be stressful, overburdened, strained, conflicted, or abusive, which then undermines the patient's health. Detecting threatening relationships. The USPSTF and the American College of OBGYN recommend screening for all women of childbearing age for intimate partner violence and domestic violence, and referring as necessary. Some clues you will see are unexplained injuries, bruises in unusual places, especially in the trunk of the body and face, history of repeated injuries or accidents, covering up for abusers with excuses, lying about source of injuries. Partner, if with the patient, may not leave the room or dominates the visit. And then there are other sexual clues that are seen are repeated STIs, early pregnancy, vaginal lacerations, fear of pelvic exam, genital or anal pain, unusual anxiety. So remember also that human trafficking is a source of these issues, and it's present in the United States. The review of systems. These are questions you may uncover problems or symptoms that you or the patient may have overlooked, particularly in areas unrelated to the HPI. This is an inquiry method called scanning, in which you ask patients questions regarding dysfunctions in different organ systems. So you're gathering information about each body system. These are yes or no questions. So keep your technique flexible. The need for additional questions will vary depending on the patient's age, complaints, general state of health, and clinical judgment. So use your judgment when you are asking questions. In your Bates electronic textbook on page 100, there is a box 3-18. There are some sample questions to ask of the review of systems. So you're basically asking about any symptoms in each body system: the skin, head, eyes, ears, nose, throat, neck, lymphatics, respiratory, cardiovascular, gastrointestinal, genitourinary, musculoskeletal, neurological, and endocrine. So you would ask questions using non-medical terminology. So you would ask the patient if he or she has experienced any of this, starting with the skin, any rashes, dry skin, itching, open areas, changes in moles or freckles, discoloration of the skin, bruising easily. Then about the head, you're going to ask about hair loss or thinning of the hair, itching, trauma to the head, excessive dandruff. For the eyes, you're going to ask if they've ever had blurry vision, double vision, redness, excessive tearing, pain in the eyes, dryness, discharge, whether they use glasses, contact lenses, and when was their last eye exam. Uh, Ears, loss of hearing, ringing in the ears, pain, discharge, itching, use of hearing aids, whether they've had any surgeries in the past, like a cochlear implant. For the nose, you're going to ask whether they've ever had loss of smell, bleeding, difficulty breathing, and discharge from the nose. For the throat, any difficulty swallowing, soreness, hoarseness, discharge, enlarged tonsils. And for the neck, if they've had any neck pain, enlarged lymph nodes. And for the respiratory, any shortness of breath, wheezing, congestion, coughing, inability to lay flat. And if they do have the inability to lay flat, then you would ask them how many pillows are being used. So we're going to continue with the review of systems in a different slide. So we're going to talk about the cardiovascular. You're going to ask the questions whether they've ever had chest pains, swelling of the legs, shortness of breath when walking short distances or even a flight of stairs. Gastrointestinal, whether they've had nausea, vomiting, diarrhea, constipation, heartburn, pain. genitourinary system, whether they've had any pain, difficulty urinating quite frequently, or if there is any hesitancy, any discharge, bleeding. Uh, More for women, you would ask them about their menstrual changes or any difficulties. Musculoskeletal, joint pain or stiffness, swelling of joints, difficulty walking or running, back or neck pain, decreased range of motion, use of assistive devices for mobility such as cane, walker, crutches, wheelchair, or scooter. Neurological, you'll ask about headaches, dizziness, difficulty speaking or finding words, weakness, fatigue, insomnia, or if they ever feel anxious. And then the endocrine, you'd ask about low or high blood sugar or blood glucose, okay? Sensitivity to cold or heat, changes in the skin color. And this concludes the comprehensive uh, interview for the adult. Thank you for listening.